Thank you all for coming to our AP seminar series. Today we have Dr. Abdulaziz Ahmed. He's an associate professor of health informatics in the Department of Health Services Administration at School of Health Professions here at UAB. Dr. Ahmed's academic background is actually all in engineering. His bachelor's and master's. And then he got his PhD in engineering from State University of New York at Binghamton. He joined UAB in 2021, and he has been working on developing machine learning framework for predicting health outcomes. And today he'll be talking about AI used in overcrowding in ER. So, Dr. Ahmed, welcome to AP Seminar.
Good afternoon, everyone. Thank you so much, Dr. Sarita, for the introduction. If my voice is low, please speak as loud as possible. So thank you for this opportunity, and thanks for coming. Today, my talk is about transforming emergency department full capacity protocols from reactive to proactive using AI, and then testing it using simulation. Dr. Sarista emailed me and told me, can you give the students like a summary of your academic journey so that students to see. Sometimes in LinkedIn, what we see is only success, right? Everybody's bragging about success, but we don't see failures. And one time I was asked to deliver like a panel at Informs conference about funding, and then I draw this timeline. Every square here represents a grant submission. Since
do you mind standing behind the podium there so that the microphone can pick up your voice? Thanks.
Is it better now?
Yeah.
So I was asked to, as I said, I was asked to talk about grant funding, and then I create this timeline. It starts from, since I graduated from SUNY Binghamton in 2016, and then I was assistant professor at University of Minnesota, Crookston campus. It's a teaching campus. I was not submitting grants, only once, or maybe on internal grants, and I submitted this Sanford, which is a hospital system there in Minnesota and North Dakota and South Dakota. They had these small grants, and then I was able to get it. It was like $2,500. And then after that, I said, okay, what about submitting to NIH? And then I submitted my first. It was disastrous. It was not discussed. And then after joining UAB, I started submitting seriously. And then every letter in the square meaning a new idea. If it's the same letter, it's a resubmission for the same idea. But if it's a different letter, it's a new submission for a different idea. So and then if it's green, it's funded or pending. I have a grant that was scored R1, 12 percentile. This morning, the status changed from council review complete to pending. So hopefully, it is coming, I'm hoping. And then I have this R21, R33 from ARC, which is what I am presenting today. So yeah, this summarized that in academia there is a lot of failures, but after it, success comes, hopefully. This is the project team. Team from our graduate student, Dr. Booth from the emergency department, and my colleague at Emporia State who did the simulation, and my MPI, Dr. Ozaiden, and our graduate student, Orhan. So emergency department is crowded, and the reason it's crowded is because it's responsible for a huge number of hospital visits or emergency visits. You can imagine, according to the CDC, there was 140 million visits in the US to the ED, which is for 43 individuals per visits per 100 individuals. 18 million out of the 140 led to hospital admission, and 2.8 million led to ICU visits. So hospital ED is overcrowding. Average waiting time could be three hours. And when the emergency is overcrowded, it affects a lot of things. It affects hospital operations, patient safety, healthcare quality. It even affects the physician and staff. Delay in diagnosis. Now, what is the root cause of the ED crowding? According to American College of Emergency Physicians, ARC, Institute of Medicine, Institute of Healthcare Improvement, Joint Commission, they all agree that ED crowding is not an ED problem, ED isolated problem. It's a hospital-wide patient flow problem that across the ED and the inpatient units. So there has to be a coordination between inpatient unit and the emergency department. So the problem is a hospital-wide problem. And when you look at the hospital operation in general, there is a very simple chart, flow chart. Patient arrive, patient gets triaged, and then patient wait until treatment. That's a very long waiting time. It could be 3 hours, it could be up to 8 or 9 hours. And then treatment. After the patient gets treated in the ED, patient either gets admitted or discharged. If the patient gets admitted, they have to wait until a bed is available in the inpatient unit. So if the bed is not available, and patient is ready to get admitted, but they're not able to get admitted because there is no available patient bed, we call boarding patient. And that time is called boarding time. So that's the bottleneck. The largest bottleneck in the ED is the boarding time. Why? Because there is no inpatient bed. Okay. So remember this. Now, what is the cure or the solution for the emergency or this patient flow? Some researchers suggested full capacity protocol. Full capacity protocol is just different levels of intervention. Every level is associated with what we call patient flow measures or a metric. How many patients are waiting? How many boarding patients? How many critical patients? And then we activate different levels. Okay, we activate level 1, activate level 2. And there are a set of intervention for every level. So what happens is, that's the root cause of the problem. What happens is, these interventions are activated when the situation is already bad. AD is already overcrowded, and you activate the intervention, situation gets escalated and still overcrowded. What we suggested is, so the situation now is reactive. What we suggested is a proactive approach. What if we develop machine learning model that could predict those patient flow measures ahead of time, like 8 hours, 10 hours, 12 hours, even the day before, the 1 day ahead, and then give them to the management. At UAB there is Center of Patient Flow who are responsible of the emergency management, and then they could deploy resource earlier so that to mitigate the overcrowding early. So what we suggest, and we came up with a holistic approach. The graph that you see here is a holistic approach that develop a decision support system where we develop machine learning model to predict the ED, the patient flow measures ahead of time, and then we integrate this patient flow measures within the UAB AHR, and then it could be used by the management. But before the deployment, you say, okay, what if we develop a machine learning model, but they're not helping. Even if you tell them ahead of time, it might not help. So we suggested developing a discrete event simulation to evaluate, compare between reactive and proactive before the actual deployment, and then see how we, if the proactive is mitigating the AD crowding or not, and then if we realize it, then we can deploy it as a decision support system that could be used. These are the aims of the project that we submitted. It got funded, and we are still waiting for the R33. Now, the overall, as I said, is to develop machine learning model. Develop a whole decision support system, but the specific study that I'm presenting today is developing machine learning model, time series model to predict the different patient flow measures, waiting count, waiting time, treatment count, and other measures. And in this study, we only focus on the waiting count, boarding count, and boarding time, and then evaluate the proactive versus reactive using simulation. And waiting count is how many patients are waiting per hour. At each hour, if you peak, if you look at the AD waiting rooms, you see how many patients are waiting. That's the waiting count per hour. It's hourly level data. Boarding count is the same thing. And then the boarding time, how many, those patients who are waiting, what's the average waiting time at hourly level. And then we develop a prototype decision support system. This is a typical machine learning pipeline that include data preparation. We get the data, because I'll show you now, we have many different data sources. We bring them together in a way that the machine learning model understand, and then we train different machine learning models. And then we see what model performed the best, and then evaluate these prediction model and pick the one that gives us the lowest error. So we get different data sources. AD tracking. UAB has keep tracks of the patient movement, every patient movement from the arrival until they leave the hospital. Like, for example, they move from the waiting to the treatment, and then maybe they went to the exam room, and then maybe went to the boarding, and then to the treatment. So that's a timestamp data that tracks patient across the hospital from arrival until they leave. And then inpatient records, that's the patient census. How many patients are sleeping at the hospital right now? How many surgeries are being conducted, and all of that, elective and emergency. And then we say, okay, we get weather data as well. We use the API for weather, and we get the weather data because we assume that the weather also affect the AD crowding. And then significant dates, we assume also that federal holidays, and if there is football game, it may affect the AD crowding. And then we get all these data, we bring them together, but of course we had to do feature engineering to bring them to a way that the model understand. And what I mean by that, aggregate them at hourly level. Everything in the data set has to be on the hourly level. And we come up with all these features: waiting count per ASI, waiting time, treatment count, boarding count. All these are at hourly level. And then data pre-processing. After bring these data, we had to do some data pre-processing. For example, drop some COVID data, like data from April 2020 to June 2020. We saw that it's unusual, it may be noisy for the model, so we drop them from the model. We also created lag, meaning my waiting count right now, I'm looking at 9 hours before. That's the lag, or 8 hours before. And then we standardize the data. We also remove any waiting time over 9 hours. So any records that have over 9 hours, after consulting with the physician in the team, that does not happen. So we removed it from the data. So all these are data pre-processing. And this to show you how's the data during COVID. The red line you see, that's the data that we dropped. You see there is a significant drop in the waiting time, and we thought it will be noisy. Actually, we have experiment with COVID data and without. And then this is the complete set of the features. We have features related to the AD tracking. So this AD tracking file, we get different data elements from it. And we have the inpatient, we have the weather data. So the first column is the data source and what the exact feature that we get out of that source. And the one that are highlighted is we have the boarding count. That's the outcome, or that's the output variable that we are predicting. boarding count, and boarding time. So we are predicting today three outcomes, or 3 ED outcomes. And then we are predicting it ahead of time, either 6 hours ahead, meaning if I run the model now, I can know how many patients are waiting per hour in the next 6 hours, or 8 hours, or 10 hours, or 12 hours. So each model for each timestamp. So it's not one model that predicts all of them. A separate model for each prediction window. And then we experimented many algorithms. In fact, we tested the most recent machine learning model that are published, including LSTM, by LSTM, sequence to sequence, time series inception, TSIT plus, time series transformer. All these, we did hundreds of experiments just to see what are the what is the machine learning model or algorithm that will give us the best performance. And then, as you remember in the previous slides, I said we have many features, right? We get features, date-related features, lag-related features, weather-related features, waiting count, etc., etc. Now you have a huge number of features. You cannot just dump them, all of them, in the model and have the model predict. They may be noisy, or they may affect the performance of the model. So we try. I'm not exaggerating if I say we try 1,000 experiments just to see what is the best combination of these features. So, and then we came up with 15 combinations of these features. If you see the X means that feature is selected for that. So, for example, DS0 has 1, 2, 3, 4, 5 features, and then you have features that has many features. You have data set that has many features. So we take all these 15 data sets and we build the machine learning model. Every dot that you see in the every dot in the chart, it's a model. It's a single model. And then we say, okay, which one that give us the best accuracy or the lowest error? TSIT Plus achieved the best performance in terms of predicting waiting count 6 hours ahead. So TI Plus give us mean absolute error 4.19, so I can predict how many patients in the waiting room the next 6 hours with an error 4.19. Meaning I can give you how many patients plus minus 4 patients or 4.2 patients. That's the meaning. And to get a sense how our model is performing, you can imagine the average waiting count per hour is 18 patients. So we are way below the average. So our model is not a flipping coin. It performs very good, like way less than the average. Average is 18 and we are 4.19. And the standard deviation is 10. So you're talking about fluctuating between 18 and almost 28. And then that's for predicting 8 hours ahead, 6 hours ahead, sorry. And then, okay, now boarding count. Boarding count, as I said, once the patient gets treated, they are waiting for a bed to be available, then we call them boarding. How many patients are waiting in the boarding? It is one of the most important ED measures or ED KPIs. So we did not use the same data sets for the waiting count. We came up again with less data sets, the one that performs well in the waiting count. Say we took them and maybe you add additional features and say, okay, and then we did multiple combinations. That's why you see here we only have 5 data sets. In the waiting count, because it was the first model we developed, we had 15 data sets. Here we have 5 data sets. And then we developed different models. Now, again, TST Plus performed very good, or the almost um, perform the best with respect to the sorry, it's okay. 4.3 for predicting the boarding count 6 hours ahead. The error is 4.3, and to relate it or to see how our model is performed, if you compare it to the mean, we have 28. The average boarding count per hour. So at any given hour, you go to the boarding, you see 28 patients. Our model can predict within 6 hours, after 6 hours, within 4.3 plus minus 4.3 patients. Now for the other time window, the 6 hours is 4.3, as I said. 8 hours is 4.7, 10 hours 5.14, and 12 hours 5.3. Meaning I can predict how many boarding patients in the next 12 hours with an error of 5.3 patients, given that the average is 28. Meaning the model, and again, and if you want to see what is the algorithm, TSIT plus perform mostly is the best algorithm, almost. And if you want to see how many features are, or what's the variance that we're able to capture, you can look at the R square. In some model we got 78%, 75%, and so we're able, the features that are used for our prediction models are capturing the variance in the boarding count, almost around 75%. And then we did extreme case analysis. Okay, now what if the we look at the testing set, and we looked at the error mean plus 1 standard deviation, mean plus 2 standard deviation, and mean plus 3 standard deviation. Meaning we want to see how our model is predicting the bad situation when the emergency is very bad, like at 3 sigma. At 3, on the average, we said 4.3. That's at 6 hours, right? In the previous slide. If you only take the mean plus 1 standard deviation in the testing set, we're able to predict the error is 4.1. And in second level of extreme cases is 4.5. The third level, which is mean, if you take from the testing set the mean plus 3 standard deviation, we say these are extreme cases. Our model is performing 7.17, which is again still within acceptable range when we present the model to the physicians. And by the way, we did the extreme analysis for 6 hours, 10 hours, 12 hours, and I'm here only showing the 6 hours. And then the model explainability, we use CHAB. Okay, we say, okay, what are the features that perform or that affect the model the most? I'm showing here only one model, which is the boarding count for 6 hours. And we see the boarding count, the day of the week, treatment count, federal holidays, and waiting are the most important. And the bottom or the least important are the temperature and football game and month of the year. Now, the third prediction model is the time. How much the boarding time per hour. And we used different algorithm as well, more algorithm actually, and linear that we did not use in the boarding count or the waiting count. We found a new algorithm that was just released, and we say, okay, let's try it, and it performed better than the others. You can see here the mean absolute error if we predict the time at 6 hours is 94. So I can predict the average waiting time plus minus 94 minutes, which you may think it is huge, but you can imagine the mean or the average waiting or the average boarding time is 600 minutes, 621 minutes. The average boarding time is huge, and we are predicting within 94 plus minus 94 mean absolute error. That's in 6 hours. In 12 hours, 122 minutes. and 10 hours 115, and 24 hours is 157. The worst is 24 hours because that's way ahead. And you can imagine the standard deviation is 200 minutes, so we're even less than the standard deviation. So our model is even less than the standard deviation of the boarding time. Now, we build those prediction models, okay. Now let's test the proactive versus reactive. So we build a discrete event simulation model. I'm going to show the detail ahead in a little bit. To compare between the proactive and reactive. And the AI model and the simulation are within the same environment. So so we use discrete event simulation, compare between the proactive and reactive. And as I said, this is the whole conceptual model of the simulation model. So you have the patient flow in the front, and patient arrive, registration, triage, just the flow chart, the very simple flow for patient in the emergency. And then you have what's happening in the back end. You have treatment, and the patient gets the patient after treatment gets discharged or admitted. But the capacity management is what's important. How we manage or how we deploy the resources. So we have the crowding threshold. So we use three thresholds. We calculate the mean over the 40 time window of 48 hours. And we say if the patient count of the waiting count is plus 1 standard deviation of the mean, 2 standard deviation, 3 standard deviation. If the waiting count is above this threshold, then we deploy resources. That's the that's the activation for deploying the extra resources for the full capacity protocol. Now, the way we deploy resources is different between reactive and proactive. In reactive, it's just based on the current values of the waiting count. So in the simulation, the simulation is running. We simulate patient arrival and all of that. We simulate the whole AD operation, and based on the actual simulation value in the simulation model, the resources gets deployed. That's the reactive. In the proactive, no. There is a prediction model inside the simulation model, gets the data from the simulation model, build the prediction, we have a trained model, do the prediction, and then if the predicted value is above mean plus 1 or 2 or 3 standard deviation, or there is also trend, so we added more conditions for deploying the resources. So predict the time window, evaluate the waiting trend. So it is not just one prediction value. We have to have a trend of, and then we have the room utilization. So if the condition satisfied, then we deploy resources in the proactive. So we have proactive is based on the prediction, reactive is just based on the actual simulation value. And these are the environment. It's all within the same code in Python, so we couldn't find any software that would enable us to integrate the prediction model with the simulation model in the same environment. So we built our own code. And then, as I said, the reactive is based on the current waiting count, and the predicted is based on based on the prediction model, or increasing the waiting trend, or the room utilization. And these are the full capacity protocol parameters. We have, so when you have resources that you want to deploy, right? We have 3 resources. Deploy 10 hallway beds, deploy 5 temporary nurses, or canceling impound transfer. Those are the interventions that we have. Now, to deploy this intervention, you cannot just put them in the system. So there is a 3-hour window to make these resources ready for deployment. These are all based on the input from the physicians. And then once we deploy the resource, it stays active for 6 hours. So this temporary beds and canceling the impound, the additional nurses, we put them for 6 hours. And then after that, we deactivate the. Then we take different performance measures for the simulation model to compare between the reactive and proactive. We calculate the average turnaround time, or you can call it the average ED length of stay. How much time the patient stay in the ED from arrival until the patient leaves the ED, even after the boarding. Leave the ED to home or leave ED to the inpatient unit. That's the average length of stay. So whenever you see TAT, turnaround time, it's the ED length of stay. And then we have the hourly waiting count, how many patients are waiting, standard deviation, waiting time, hourly holds, number of admitted patient or boarding patients, and how many times the ED went above the threshold, how many peaks we have. We look at the situation and say, okay, because that's the interruption in the ED. The more peaks you have, meaning the more interruption, the more like you are going beyond the mean. Your process is not smooth. That's the peak threshold and peak time. And then total deploy, how many times we deployed the resources, the additional resources, and how much the protocol duration until the situation gets cooled down. And then we run the simulation for 1 year, 10 replicates. So you have 1 year, 10 times. That's the simulation time and number of replicates. And before you do when you do any simulation model, you have to validate it, meaning compare the actual system or metric from the actual system with the simulation model. And we took the average and standard deviation of the waiting count, and you can see the p-value is small, meaning they are very close to each other, meaning the simulation model is very similar to the actual system, meaning our simulation model is validated. This is the interesting results. For the situation or the threshold situation, when the mean plus 2 standard deviation, you can see the average, we're not reducing the time. We concluded that deploying or using proactive FCP, meaning deploying the resources early, it reduced the time, but not significantly. You can see the blue is reactive, and the red is, the blue is proactive, and the red is reactive. It does not reduce the time significantly. It reduces it a little bit, but not significant difference when you do t-test. But the significant is in the how many times or percentage of weight above the threshold. The percentage of time we went above the threshold, above the mean plus 2 standard deviation. In the proactive, it's way less, meaning my process is smoother than the reactive. We have less disruption, we have smoother, and then the average protocol duration in the proactive is less, and number of deployment, the proactive deploy the resources more often than the reactive. This is one situation, which is the mean plus 2 standard deviation. In the mean plus 1 standard deviation, which is the threshold for activating the full capacity protocol, again, we found very similar results. We didn't find significant difference in the waiting time, waiting count, all these measures, but significant in the percentage of time we went above the threshold, number of deployed, and the average duration of the protocol. The same thing for the mean plus 3 standard deviation. We are missing one graph here. Sorry, I forgot it. But we confirmed the same result. In terms of waiting count and waiting time, we didn't have a huge or significant difference when you do the t-test. But for the percentage of weight above the threshold and total deployment, there is a difference between proactive and reactive. Now we proved that the proactive can help using AI using AI as a mean to deploy resources early can help smoothing the ED operation. Now, okay, now we want to put it as a decision support system. So we build a prototype that automate this whole thing. Automate getting the data from the HR, from the weather API, from the API for the federal holidays and all of that, and then build a front end and back end system, and so that we can just hand it to the HSIS so that they can deploy it in TUAB hospital. So this is the whole architect of the system. You have data acquisition, you have web application. So in the back end, you have data acquisition that takes care of the data pre-processing, takes the raw data and convert it in a way that the model understands it. And then you have web app. You can log in, username and password and all of that. That you can run the prediction model. You can choose what is the hour that you want to predict. You want to predict the next 6 hours, 12 hours, 10 hours, whatever the time window that you want. And then you can also do retraining. Like after 1 year, maybe the model will not perform well. Then we can retrain it and then use it again. You can even get streaming, show different statistics like what is the year, what's the how many patients, and all of that. And this is how the system will look like. You do prediction, and it shows you the forecasted and the actual. And the conclusion is we developed different prediction model to predict what we call patient flow measures ahead of time, 6 hours, 8 hours, 10 hours, 12 hours, and even 24 hours. D-linear and TST plus and TSIT plus perform the best across the board. And then incorporating AI within the to deploy resources, enhance the proactive, and you have less crowding peaks, smoother operations, and less capacity distress. So for the future direction, we want to also predict patient flow measures for the inpatient, like how many patients are sleeping in the hospital, predict those, how many urgent surgeries, those are important measures. And then we try to get the 911 call. UAB keeps track of, or there is a way to get 911 calls in the whole Birmingham area. And then among the Birmingham area, you can select which one led to an ambulance or a hospital visit. You can filter it. And then we tried very hard to get that data, but we couldn't. Hopefully in the future we get it, and we improve the prediction models. And then what you saw here is the proactive just tell you the situation. What would be the situation in 8 hours or 10 hours, whatever. I wrote a different grant. It didn't get funded. Hopefully I'm submitting again. The system not only telling you what is the situation, but also tell you what to do about it. So in the future, I'm planning to use agent-based simulation. It's like a time machine that takes you to 10 hours, 8 hours, and simulate the OR scheduling, bed assignment, most critical resources, imaging resources, lab resources, and then that's using agent-based simulation technique, and then incorporate the prediction model, and then enable the user or the end user to say, okay, what if we adjust the schedule of the inpatient, how the situation will look like? What if we adjust the bed assignment? What if we increase more resources? What if we increase more nurses or more physician, or maybe allow overtime for physician? What would be the situation? That will give you a whole idea, not only what is the situation, what you do about it. That was the grant. Unfortunately, it didn't get even discussed. Hopefully in the future. Yet. Those are the papers if you're interested to read. We have 3 published papers, and we are working on 2 papers currently. The simulation part, we're still working on it, and the decision support system, we're very close to submit it. And then I have to say that this project is funded by ARC. Was a huge cut, not a huge cut. They planned a cut, but now I think ARC budget is fine. So we got the R21 We're still waiting for the R33, which will enable us to deploy the system at UNP. Hopefully we get it. And I'll be happy to answer any question.